Yeah, good afternoon. At the outset, I thank Vijay for this opportunity. And this topic actually I could make only yesterday and day before yesterday. Only 2 days I got the time to do this. This is lymphadenectomy. You know that it's one of the very important aspect of esophageal surgery. And but the optimal extent of actually the lymphadenectomy is still controversial. There are a lot of studies on that. It's very controversial. Why do we need to do a lymphadenectomy at all? One is to stage the disease, that's a very, very important thing. And then for the loco-regional disease control is other one. And then it has shown to improve the better overall survival. So that is the one. And again, more than the lymph node numbers, it's actually the lymph node positive ratio that has shown to be a better prognostic marker. If you look at the you saw the lymphatics, actually there is a lot of lymphatics. It's a very complex lymphatic system that you have. And the lymphatics start even in the submucosal area itself, and you have an extensive network in the submucosal area. And also you have a multidirectional flow, and you can see actually the lymph flows in all directions actually. And that is the reason for which the esophageal malignancies, they can involve in all the compartments, also the skip metastasis. If you look at whether it's a squamous cell and adenocarcinoma, actually it's more with adenocarcinoma, squamous cell carcinoma. And so you can also look at the locations of the lymph nodes in two things. And it's adenocarcinoma, it's more of the lower one, abdominal and thoracic, and the squamous cell you can get even extending up to the neck. So this is one agency staging where they just give the number of lymph nodes are taken as the criteria. Here it's not based on the location. But whereas if you go to the Japanese classification, it's more of the location of the lymph nodes that have been taken into consideration. And if you look at the nodal stations, this is a very complex one actually. It is just to show that the regions where like cervical, it's more of the neck, and then it's the location that is there. It's actually based on the possibility of the metastasis and also the survival. So this is just a diagram where if you have a cervical, the cervical one, it's more of the lymph nodes are more in the upper one, group one. And then here you can see, but when it comes to the upper thoracic, it's actually you can have the lymph nodes even in the abdominal area, that's metastasis. And in the mid-thoracic, again, you have all the three regions that are involved, and even in the G junction, and there also you have almost all the regions. You can see that even the lymph nodes are there in the cervical region. So, and this is G junction again, we have that. And we have two types of lymphadenectomies. One is 2-field and 3-field. So naturally 3-field means where you are doing all three fields that you are taking, lymph nodes are removed in all the three fields. Whereas 2-field, again, we have three types of ones, three types that have been described. That is, one is the standard mediastinal lymphadenectomy where you do only the subcarinal is taken. And in the extended one, you take the subcarinal, and also on the right side, a little up onto the right side, you go on the recurrent laryngeal nerve under the and the paratracheal, whereas in the extended throatal mediastinal, you go to the left side, I mean the right side also, the left. So what is an optimal lymph node dissection? Is just the numbers or also the location? So whether you need to do both. So both are actually important for this thing. So one is the nodal involvement. Actually, depending on the site of involvement, like they say, if it is only local regional lymph node involvement, you have a better survival when compared to the distant lymph nodes. So actually the location of the lymph node is very much important to decide about the survival. And also, if you look at the number of lymph nodes, that is also very important. It has been shown about 16 lymph nodes is very important as per the AJGC criteria. But again, it's not just 16 that is important. It's actually based on the tumor staging also. Like if you have a more T3 and more, then probably you may need to take more lymph nodes, like 30 and more than that. And it's again, the positivity, lymph nodes positive, it again shown that is because if you have more than 3 lymph nodes, the chance of having a systematic disease is more than 50%. And if it's more than 8, it has been shown to be almost 100%. So the extended resections that have been spoken about, they have shown that they are beneficial not only the patients who have less than 8 lymph nodes, but we don't know which are the patients who actually have these 8 lymph nodes. So it's very difficult to decide who are the patients who need to go for extended dissections. So it's basically, you need to do a complete 2-field lymphadenectomy in all the patients.